Hello, and welcome to the Love Mia Vita podcast. I'm Jerry DiPiano, CEO of FemPharma. Thank you for joining me as we discuss all things women's health and wellness. Please note that this information is simply that. It's information to help you to think through your decisions. Please consult your medical practitioner to discuss your personal situation. Thank you. So welcome to the Love Mia Vita podcast. This is Jerry DiPiano, and I'm here with Perri Borish, who is a licensed clinical social worker with 2 decades of experience. And today, Perri's going to share some information about postpartum depression. But before we jump into that, Perri, I'd love it if you would share more information about yourself, your background, and whole heart reproductive maternal health, rather.
Sure. So it's actually whole heart reproductive mental health. We changed the name a couple years ago to be more encompassing to what we actually do. And I want to thank you so much for having me here, Jerry. I'm very impressed with your desire to support other women and give women a platform, not just to learn, but also to share what they know. So I really appreciate it.
Absolutely.
So whole heart reproductive mental health, I established over 20 years ago, pretty much because I had my first child and there was nobody in Philadelphia who was really specializing in maternal mental health. And I realized that as soon as I started talking about it, everybody else wanted to talk about it too. And so I really built a specialty around that. And it has grown pretty much as I've grown developmentally. So we treat adult women across the reproductive lifespan. So everything from not being able to get pregnant, pregnancy, postpartum, grief and loss related to terminal abortion, termination for medical reasons, stillbirth, neonatal death, and then perimenopause and menopause.
So pretty wide range and many life transitions for women, which is really important. And interestingly enough, there's not enough information or data that we have collected that clearly points to the vast number of women that may be experiencing these sorts of issues. Some of the data that I saw really looked at it more globally, but what has been your experience with in the field?
So we usually say it's about 20%, and we talk about it. We call it a perinatal mood and anxiety disorder. We're no longer really just referring to it as postpartum depression because the mood disorders often start in pregnancy and they can last up to 2, some people say 3 years, even postpartum. So that could be anything from postpartum depression, postpartum anxiety, postpartum OCD. So it's a wide range and can look quite different in each person. But one thing I should add too, I mean, there are certain risk factors that can happen that can lead to a perinatal mood and anxiety disorder, even that just happen during birth, for example. So if you have a traumatic birth, that puts you at higher risk for having postpartum depression or postpartum anxiety.
Okay, because I know we look at environmental factors that may predispose women to this, biological factors, genetic factors, and this is one of the other factors that may predispose you to this. Tell us about, you talked about anxiety, OCD, and depression, which is really an interesting breakdown and very important. So perhaps you can expand upon that.
Sure. So I mean, you can develop a perinatal mood and anxiety disorder in pregnancy or in the postpartum period. For some women, it looks more like depression, and for others, it looks more like anxiety. So it could be, anxiety can include scary thoughts, for example, ruminations or worry, excessive worry about something happening to the baby or to even to yourself or to your partner. And postpartum depression would look much more like a major depressive episode where perhaps you're flat or you're crying a lot, right? Lack of motivation. And there's a tremendous amount of things that contribute to these presentations. And when they show up and how they show up is quite different in everybody. So there are certain ways we can mitigate the risk. So my favorite kind of person to treat, and the reason I love this specialty is because everybody gets better and it's really hopeful and they come back after they have their next baby or the next major, life event. But we can mitigate the risk by preparing for the things that we know are going to be true, right? So we know that you're going to be sleep deprived. We know that you need community support, familial support, some sort of resources, right? And so by preparing in the pregnancy, we can actually bring down the risk of postpartum depression and anxiety in the postpartum period.
What are you indicated that this starts to emerge, it could emerge during the pregnancy and then following the delivery of the child. So what are some signs that a woman who has never experienced any depression, anxiety, or OCD would start to observe in her own behavior that would propel her to visit someone with your expertise?
Usually someone else, some other provider is sort of saying, hey, it sounds like you might want to talk to somebody. Usually it's a psychiatrist or an OB/GYN or a friend even, or a partner. I would say it's not that they haven't experienced anxiety or depression. They might not have registered it as such or seen it as problematic because a lot of anxiety can be quite motivating, right? And if you're a type A person and you're driven by your anxiety, it's often not seen as a problem until you become a mother. And then you can't actually, like, that coping skill doesn't work anymore. And you need to develop other coping skills because the coping skill of just sort of chasing the anxiety and achieving, or being a perfectionist no longer works when you have to take care of a baby.
So in someone who is a type A driver, for example, who is used to multitasking, and by the way, people that have OCD are very comfortable multitasking and they check every box, right? Getting it
Mhm.
all done. So in this case, when you're pregnant, and in my case, setting up the nursery in like a week. Yeah, so I probably had a little bit of OCD there. I had to have it all done. I wanted to make sure that it was all perfect before baby arrived. Baby arrived early, so that was a good thing. But, I laugh about that, but it's interesting that you may not, you're right, you may not recognize this until you started, sharing this. I didn't recognize it in myself. So and now the
Yes.
baby is not a baby anymore. She's an adult woman. But yeah, it's interesting that you share that. And anxiety and OCD and depression may manifest themselves differently depending upon your temperament. So
Mhm.
what other personality disorders you may experience and you may not recognize them in yourself.
Right. And postpartum OCD, that can look like intrusive thoughts or really scary thoughts that are actually very disturbing to you. Um, but usually there's some hint of that before, like you might have OCD at baseline or be predisposed to that or have had high anxiety. Um, and and I think there's a difference, I mean, obviously there's a difference between a perfectionist and working on those sort of behavioral things, right? And where the perfectionist and the postpartum, or the lack of women being able to get their needs met in the postpartum period kind of meets up, right?
Right. So interestingly enough, so we used to refer to OB-GYNs as, or contemplate that the OB-GYN should be the primary care provider for women, because let's face it, they're spending a lot of time with you. Same with the nurse practitioner in women's health care. So if you're a woman that does not see a psychiatrist because you haven't had a diagnosis in the past, or perhaps you haven't identified with any of the symptoms that you were mentioning, you're seeing your gynecologist or your OB, and do you think they're adequately trained to ask these kinds of questions? Because let's face it, you've gone through years of training. We know psychologists and psychiatrists, same thing. The DSM-5 is, something that is a Bible. So do you think the OB-GYN is capable of making these diagnoses, or do you think there's an opportunity there for gynecologists and OB-GYNs to become more savvy about these types of interactions?
Absolutely. I think the I think there's amazing OBGYNs who take excellent care of patients, and it's because of them that I have such a robust practice, because there are so many amazing OBGYNs in Philly. The problem is that they don't have enough time, and that's a systematic problem, right? I think this PCPs aren't typically trained, and they also don't have enough time, but I think the OBGYNs have some more training. And one of the things that we do is actually we do a lot of training of providers, and and we do it for free because it's that important. We see, we sit on the other side of the couch from their patients, and without trauma-informed care, there can be so much additional trauma and so much grief that women are experiencing on top of what is already happening as a birthing or a postpartum woman. And as you know, I mean, there's a million societal issues and religious issues and cultural issues on top of, what makes it so pressure filled. But yes, I think there's excellent OBGYNs, and yes, we all need more training.
Yes. So interestingly enough, you mentioned something about the primary care practitioners, and all physicians are taxed to the max. In the scenario of the woman that goes into
Mhm.
her OB-GYN office, and maybe she is a woman that's starting to exhibit some of these, we'll call it anxiety or depression or OCD. Is there perhaps an efficient way that an OB-GYN can gather this information without spending an hour?
Absolutely. We have excellent screening tools that can be distributed by anybody. The OBGYN doesn't have to be there, and anyone can read them. And if the screening tool is a certain level or above, then they can make a referral. So that is, those exist for sure. And I think there are some really basic questions that an OB-GYN can ask their patient. I think it's most important, though, to remember the context of the patient, right? Um, why is she coming in? And creating a space where you just sort of ask an open-ended question, like, how are you doing? And then ask her again, how are you really doing? So I think there are some, I mean, for sure the screening tools, but also just like really like, I want to know how you are. I'm not going to tell you how you should be. I want to ask you how you actually are, and I'm going to listen. I mean, and treating everybody as though they have experienced some sort of trauma, I think particularly when you're dealing with reproductive women, is really important, because there's so much re-traumatization that can happen if you don't read the chart, or you ask the wrong question, or you make assumptions.
Can you expand upon that when you say re-traumatization? I think that's a really important point.
Sure. I mean, for example, I run a group for mothers who have left their religious cult, or are post-evangelical, and they've been traumatized, right? And so when they show up to the OBGYN, there's a tremendous amount of trauma that they've already been through. The OBGYN may not know that, right? And they may not be able to differentiate between that trauma or, let's say, birth trauma, right? But so if you treat everybody as though they're traumatized, right? And that means like informed consent, right? Telling patients what you're going to do, right? Not assuming that every birth leads to a live baby, or that every pregnancy leads to a live baby, right? Um, Reading the problem list on the chart, making sure that you actually take the time um, to know what is she coming in for, right? And like what are the important things about her history that I need to know? And if I don't know or I'm not sure, I'm not going to ask questions that could be triggering, right? So if she's having trouble, let's say she's postpartum in the hospital, she's having trouble breastfeeding, you're not just going to grab her boob and shove the baby onto the boob. You're going to ask her permission. Is it okay? Can I help you? Right? Um, or asking for what she needs, or if she's lost her baby, there's a whole host of ways, things you do not say and things you do say, right, to help the mother and the family get through that.
Yeah. We tend to think about, when we talk about postpartum depression, could be at any point during that pregnancy where there's pregnancy loss. Maybe we could spend a few minutes on what happens with pregnancy loss, and it could be elective, or it could be that it was something that the body, was incapable of continuing on with the pregnancy. So very different situation, I imagine, but the outcome is the same.
Yes, there's termination where you have to terminate for medical reasons,
Mhm.
and there's stillbirth, and then there's neonatal death, and they are all excruciating. There's also miscarriage, but we usually say that's before 20 weeks. Um, but what a lot of people don't know is that, I mean, it's a death unlike any other, because the baby dies inside of you, right? And after 20 weeks, you have to deliver the baby. And then your body, I mean, your brain, we know our brain changes, right, in pregnancy. So your body and your brain still think that you're pregnant. And so you go through all of the sort of normal post pregnancy things, right? Like lactation, only there's no baby. So yes, that can be excruciating. Or if your baby is stillborn, right? Or you show up at 37 weeks and there's no heartbeat, there's no fetal movement, and you have to deliver the baby. If you either are having a vaginal birth or you're having a C-section, right? And so you're also, potentially having a difficult labor, right?
Yes.
And then there's no baby to go home. And that's excruciating for those women.
And I would imagine that that amplifies the postpartum issues, the depression, the anxiety, the OCD. What did I do wrong? Why did this happen? Um, all I can't imagine there's the range of emotions must be horrible.
Horrible and lifelong.
Mhm.
I mean, you've lost you're grieving, mourning, absolute, absolute. You're just on a different planet, essentially, from everybody else. And yeah, I find it extremely powerful to sit with those women and be with them in their grief. Um, it's shocking to me that it's still happening over and over again, even in Philadelphia. The number of women that I have seen over the last 20-25 years who have lost their baby is unbelievable.
It was interesting to look at some of the again, look at the data on the number of women who have actually had a termination of pregnancy. And again, this was not necessarily an elective termination of pregnancy. This is a result of other factors. Much of that, not, it's the prenatal care that was either missing, or something that that wasn't diagnosed properly. A woman did not, know that she was, that she had certain risk factors, Could have been that, she had high blood pressure. It could have been that she had some other pre-existing condition that was unknown before she actually became pregnant. Obesity. So there are a whole range of health issues that may have predisposed her to early termination of pregnancy. You're right, in a major city.
Yeah, I've even heard of, I've heard blood tests that were wrong or scans that said there was no problem and then later on showed a problem. Yeah, there's really a sense of being out of control often when you're pregnant, especially if you've had previous trauma, or you've had a miscarriage or you couldn't get pregnant. Um, there's a ton of anxiety in those pregnancies following something like that.
So I would imagine that as a person that is trained, such as yourself, the way in which you interact with that person is quite different than someone who's had a child, healthy child, uh, but it still has some of these other issues that she is facing.
Yes, absolutely. I mean,
And
there's a lot of loss in motherhood, in normal, healthy motherhood that we don't talk about. And we certainly, I help women name those losses, and sit with them, but that is entirely different than the kind of loss that we're talking about now, right? Where there is no baby, or they've lost a baby. And sitting with that grief, I mean, I honestly feel like it's such a privilege and an honor, and the trust and the vulnerability that my patients have is, it's hard to describe in words, really. Like I'm literally, it's like, it's very, very humbling. Yeah,
it's it's got to be it's got to be challenging for the patient, but also gaining that trust is a credit to you, what you do, because let's face it, it is, establishing that kind of intimacy with a professional really does require you to be, have that level of empathy that makes a person feel safe
mhm.
and cared for, right?
Absolutely.
So that's
Absolutely.
a credit to you. And finding the right professional is important. We just talk about, you know, finding the right therapist or the right HCP is really like playing match, right? Match.com,
Yes.
right?
Yeah,
Culturally, spiritually, professionally, all those things have to align properly, or it's not a good marriage. It's not a good partnership, and it really does need to be a partnership with your patient, with your client.
absolutely. Absolutely. It's an amazing profession for that reason. And, like you were saying about doctors, I mean, we're constantly going to trainings and having to do continuing education. And so it's also like a lifelong learning that I love about this profession as well.
When these women have a normal healthy child. I don't know
Mhm.
if that, normal is the pretty broad definition of what is normal.
What is normal?
What is normal? But let's assume that the pregnancy, goes to term and the baby is born, and now the whole dynamic changes. So perhaps if it's your first child, that's a different dynamic than if it's your third or your fourth or your fifth. Different than if you have a partner, whether that partner is engaged, who's getting up in the middle of the night, who's going to work in the morning. So all those social factors play into how things turn out and whether the consequences exacerbate what might be postnatal depression or what support helps to support it. So maybe you can share a few of your thoughts on that.
Sure. Yeah. I mean, having community support, family support, whether you have a partner or not, those are huge factors, absolutely, in what your postpartum period is going to look like. It's really hard to know because the first time you have a child, right? Like it's kind of like take your life and turn it upside down. You have no idea. You think you know what it's going to be like, right? But it's not at all the fantasy. that we all are indoctrinated or grow up having, right? Like your reproductive story actually starts when you're a little kid for a woman. Little girls have fantasies about how they're going to be as a mother, right? And so that is it's often not the way we fantasize that it's going to be. I thought with my first kid, I immediately jumped from having the baby to we were going to be skipping and hands and like running around Rittenhouse Square Park. I didn't even realize there was like going to be a year where he couldn't walk.
Right.
Um, so yes, I mean, I think all of that, the fantasy, the myths, that goes, it's really when, reality meets, like, doesn't meet your expectations, and that's where there's a lot of anxiety. And then if you are in a couple, right, it can be very stressful on the relationship itself,
Yeah.
in all kinds of ways, right? Emotionally, sexually.
I learned that you have to ask for what you really need. So I was working in big pharma and returned to work, and my husband had his career too, and we had this infant, and I was the one getting up in the middle of the night to do the feedings and the changings and so forth. And I reached a breaking point one night. My husband was wearing an eye mask and he was wearing earplugs.
Oh my gosh.
I won't use the bad language that I used when I ripped off his eye mask and screamed got the earplugs and screamed in his ear, said, "Your turn, I'm done."
That's hilarious.
And before that, somebody asked me, "Oh, you're getting up in the middle of the night and you're doing all these things for your kid." And I said, "Oh, I love it. I'm just so happy to be a mom. It's my miracle baby," because I had endometriosis. I didn't think I'd ever get pregnant. So I was so overjoyed. Oh my gosh, this is the greatest thing ever. And then I was like, I am so tired. And I want to strangle you. So, and not my baby, my husband.
Yes, yes,
And he said,
yes.
"Oh, if I probably had some postpartum anxiety as well as my OCD, right?
Or you were just really sleep
I
deprived.
couldn't deal with it anymore." I was like,
Yeah,
"I have maxed out. Sorry." But
yeah.
from that point on, we had a system and he was getting up too, which was amazing.
Oh, wow.
Your night, you're on. But yeah, I think you also forget, right? So you have this, fantasy. Oh, we're in this beautiful little family, this wonderful husband. We have this beautiful little baby, and I don't mind getting up until you mind,
Yep,
till you
yep,
reach that breaking point.
absolutely. And
Yeah.
everyone hits that if you're sleep deprived. I mean, it's literally torture to be sleep deprived. And even a lot of the doctors that I see who are used to, being residents and not sleeping or doing overnights, the the factor that you add in when you have to take care of a baby nonstop is even too much for people like that who are pretty resilient and used to not sleeping.
Or if you have three other children. So this might be your fourth child. You have three other children ranging in age from who knows what. Even if they're not close in age, they're school age, but then you have this young child, you're still getting up, making breakfast, getting them off to school, doing whatever you do. If you work outside the home, then you're doing your thing outside the home too. So there's a lot that goes on. And let's face it, women disproportionately pick up the load. So we shouldn't kid ourselves. So one could understand, you said something about support systems, and it sounds like that is probably the number one thing, is the support system to help you with moving forward. But if you don't have a support system, wow, that has to really impact the probability that you can be successful to move forward easily.
Yeah, a support system of any kind, community support. I actually started running groups at Center City Peds for that reason, because women needed to have the support of each other. Um, but a plan too for sleep. Okay. Like, so if it is just you, right? Like, when are you going to get sleep? When can you at least be horizontal, right? Who can you ask to come over and hold the baby so you can take a shower or you can eat something without having to hold the baby at the same time, right? Um, Figuring those things out ahead of time, right? Like, what do you really need to put? I call it the emotional suitcase rather than the hospital suitcase, like,
Right.
which is what everybody focuses on, right? We need to talk about like what's going to be in your emotional suitcase for the fourth trimester. And how are you going to nurture yourself, or how are you going to ask someone else to nurture you? Because really, when we become mothers is when we most need the nurturing ourselves.
And for some women, they don't have their mom, so they are mothers without their mom. I can't imagine what that must be like. My mom moved in with me. She grew up in Baltimore,
Wow.
so my mom told my father she was leaving for a few months so she could help me. She knew I was totally incapable of being a mother unless she was around, and she's kind of correct. She,
Oh,
I always I can't express enough gratitude for that. But knowing that it must be horrible not having your mom when you become a mom.
it can be, yes, actually. And we actually run a group right now. We're running a group for moms who are mothering without their mother, who have lost their mother. And because it is so unique to become a mother without your mother. It can feel really isolating and lonely, and there's a lot of fantasies of like, if my mom were here, right? And so that can make the grief even, or the loss, even more profound.
So special circumstances with that. Moving forward, so I always like to think about there is help,
hundred
even
percent
with a therapist like yourself. And this is cognitive behavioral therapy or therapy. It doesn't necessarily involve pharmacology. You're not prescribing drugs.
Right.
Um, what is the process?
I would know in the first like 1 to 3 sessions if it wasn't a good fit. And then if I wasn't the right therapist, or I didn't feel like I could support her for whatever reason, I would refer her out to somebody else who could. But generally, when someone shows up in my office or with any of the therapists that work for me, I've already kind of screened them and know, like you were saying, who's going to be a good match, right? Um, but yes, sometimes you need to collaborate with a psychiatrist or their OBGYN for medication, or physical therapy for, pelvic PT. Sometimes it's an acupuncturist. Sometimes you have to gather the resources, or help them gather the resources that they need, depending on what is going on with them. And sometimes people start therapy for a crisis or some particular, reproductive issue, and then they like it and they stay just for the supportive psychotherapy. Um, and then they leave, and then something else happens in their life, and they come back, and that's part of what's so rewarding. I do want to say there are some really good free resources. Postpartum Support International, um, and I don't get paid to say this, but they have amazing free resources. There are groups for almost every single kind of mother you could think of on the planet that are free. So and that's international, and you can be anywhere, and join any of those groups virtually. So there are ways to get support other than going to a therapist. If that's, you know, cost prohibitive, or you're not in an area where there is a therapist, although now so many people do online therapy, that's less of a problem.
And we'll provide those links so that women can avail themselves of those services. And these resources are probably going to be very valuable to them. So I appreciate you saying that. And it's really encouraging to hear that in the pre-screening process, you can identify those women who perhaps have a more significant issue that requires more intensive kind of treatment. And I'm thinking perhaps of a woman who comes to you with some pre-existing mental health challenges that are now exacerbated by what may have happened during or following her pregnancy.
Right.
And there those resources are also very helpful. And so I appreciate you also sharing that, but also very, very helpful to know that for the most part, this works.
Therapy works for perinatal mood and anxiety disorders. Therapy works, and a lot of a lot of it is just holding a space for these women, where they can say anything and your compassionate, caring, empathetic therapist really listens to you, and also normalizes what you're going through, because often first time moms don't know that this is all normal, right? They think there's something wrong with them.
There is that component, which is the partner component.
Mhm.
And what about the engagement of the partner in this process?
So if a woman shows up pregnant in our office, we always bring the partner in one time in the third trimester, usually early in the third trimester, because you never really know when she's going to go. And we do psychoed with the partner, and we work on whatever she is afraid she's not going to get support around with the partner. And we sort of do a lot of direct, like, this is what we need, and I need you to help my patient so that she can be the best mother and, person, whatever, to herself, right, in the postpartum period. And that's really helpful, and I think pretty unique, and sets them up for a lot of, I mean, even if nothing else, it sets them up for communicating differently around this than they were previously. And that alone is really valuable.
And do you find any resistance getting the partner to come in? And what do you do if you find that a woman says, well, you have to come in with me, and perhaps her partner is resistant?
I don't think I've ever experienced that, actually. I find that they want to be supportive, and they're usually pretty, even if they're resistant, we can deal with the resistance enough, and we can disarm them immediately, when they walk into the room, by explaining that they're really there to help me help her, right? And that, and thanking them for coming. I mean, that immediately usually disarms people. Plus, once they're here and they're in my vibe, they usually feel pretty comfortable. And when they feel like they don't know what to do after that, they feel better about reaching out to me if their wife is in crisis or their partner is in crisis. And that's invaluable as a therapist.
Absolutely. Absolutely.
And it also sets the stage for the mother, right, the birthing person, to feel comfortable talking to the partner about it, because we've already now done it, right? We've said these are the things to look for, these are the things that are normal, this is outside of normal, right? And so it's already giving them some communication tools and further connection around, like, what could be possible, because also the partners don't know if they've never done it before, right? They don't
No,
know how hard it can be, or how challenging or scary.
you said something about an emotional suitcase. I think about both parties having that suitcase that they carry with them.
Mhm.
I want to know what's in each suitcase.
Well, Jerry, I created it. Do you want to see it?
Yes.
I created it with this amazing artist. I don't know if I can send it to you.
Very cool.
With postpartum women, it's a lot of back to basics, right? Like, how are you going to rest? How are you going to get water? Right? How are you going to eat? Um, who can hold the baby so you can shower? Can you get some fresh air? Can you get a little sun in your face? Are you able to take a walk around the block, right? What do you need from your partner? What do you need from your girlfriends, right? Um, what, how are you going to get in touch with your OBGYN if you're having issues and you don't want to wait till the 6 week postpartum, you know, visit, right? Um, just back to basics, like who can hold the baby so you can sleep, right?
Right.
And can you put your to-do list, right? Like your never ending to-do list, can you put that aside and put yourself first in some way, whether it's just having a cup of tea or just literally being horizontal and not folding the laundry for 20 minutes, right? So a lot of the nurture, and I don't love self-care. I mean, I like the concept. I don't love I think people get caught up in how do you do that. So I really like to think about it as nurturing. How do you nurture yourself, and how do you nurture the relationships, right, that you need? Obviously not just with the baby, but with your partner or your family, right? Whoever you're dependent on. And women have a really hard time with that, and we're not taught to do that. We're taught as women to put everybody else's needs first, especially when you become a mother, right? So one of the things that we talk about a lot is like, how do you triage? Like, what is the one thing that you have to do tonight that cannot be done tomorrow? And then you're allowed to do that one thing on your to-do list, but everything else can wait till tomorrow, right? Or, you know, what's the one appointment you have to make today for your baby or your kids or your, you know, yourself, right? Your follow-up, right? And then in the 15 minutes that you have free, you know, what can you do for you that's tiny and small, right? Even if that's all you get.
The blessing of motherhood is indeed a blessing, and we never want to forget that. But we also have to remember that in order to share what is in your cup, you actually have to have something in your cup.
That's correct. And if you don't have it, you can't give it,
Right.
right?
Right.
You can't. And sometimes that's the way it is, right? And you have to be able to say, like, I don't have it right now. Tomorrow.
So it is overwhelming. You can understand why, these types of depressive, anxiety, and obsessive compulsive issues may arise during a period of time when you're changing biochemically. And I think about the biochemistry of this. We won't go into that, but there's the biochemistry of this.
Mhm.
And then there are some of the social factors, there are the genetic factors, and then there are the environmental factors that are pressing down on you. If you work outside the home, if you've got a career, maybe you work in an environment where you know your employer is not going to be family friendly. You think about your work-life balance. Can you afford childcare? You know, all those issues play, wreak havoc sometimes on your psyche.
Absolutely.
So we don't mean to trivialize that. That's why people like you exist, and thank God for that.
Yeah. Yeah. Yes. Well,
Harry, it was wonderful having you on the Love Mia Vita podcast. And we hope that you will join us again as
I'd
we
love to.
explore some of the other issues facing women and the challenges through their reproductive mental health lives. So we go through all of these wonderful transitions. They are wonderful transitions, but we also need to pay attention to our mental health because women don't do a great job of that.
Yes, that's for sure. And societally, we are not supported in
No,
that, unfortunately.
no, we are
Yeah,
not, but we aim to change all that.
that's right. We do. We
One woman
definitely
at
do.
a time. One
Yeah.
woman at a time. Thank you once
Thank
again.
you so much, Jerry. This
Remember
was
to love
great.
Mia Vita, love your life.
Thank you.
Bye bye.
Bye.
Thank you for joining us on the Love Mia Vita podcast. Love Mia Vita means love my life, and that is a mantra we should all live by. Please like and subscribe wherever you get your podcasts, and check out our website at fempharma.com. Remember to live well and love Mia Vita.